can sit right over there, my dear.
Okay, thank you.
Dr. Blum will be in just a few minutes.
He will be shortly.
I'm Ron Blum. I live and work in Patton, Maine as a family physician. I really enjoy my practice here, but the sad reality of it is the office practice isn't adequate to support me as a physician and my family. Here? Good. Several years ago, my accountant suggested I just close the office. From a business point of view, I'm not really making any money there. But I couldn't walk away from patients I've been taking care of for over 30 years.
Primary care in America is really facing a crisis, that it's very difficult to get qualified, committed physicians who want to choose the lifestyle that is required to provide primary care.
There is no doubt that primary care has already collapsed. There is no supply of physicians doing primary care.
As our population grows, we certainly continue to need primary care physicians. Whether or not the population sees this as a problem with primary care, I don't know.
If you look at the current healthcare system, we have about a little over 700,000 practicing physicians, and we know that about a third of them are already planning to retire in the next 10 years. We are going to have a crisis like you cannot imagine.
Even though the healthcare debate in this country is largely over, there is still plenty of disagreement over whether we are headed in the right direction. But the one point virtually everyone agrees on is that there are not enough primary care doctors to meet current needs.
I think we're already starting to see some of the impact of the realities of primary care, meaning people who are baby boomers in medicine like myself who are primary care docs. We're not quite at retirement age, but we're coming pretty close. And the pipeline has not been refilled, meaning our replacements are not going to come along at the pace that we're needed to meet the needs of our society.
Okay. Have you ever thought about what would happen if there weren't a doctor to see you? As the first line of defense in treating medical issues, the challenge of finding enough primary care physicians to fill the pipeline is daunting. No part of the country is immune. From the rural farmland, to the suburbs, to the inner city, all Americans will soon have to find a doctor to provide long-term preventive care. With this national epidemic on the horizon, Dr. Patricia Noble, a pediatrician in Lincoln, Maine, knows there will always be a need for doctors. But what happens when there aren't any around?
People are always going to want to have a doctor. And so they'll call around until they find someone who will be their doctor. And their doctor is almost always going to be a primary care doctor, whether it's a pediatrician or an internist or a family practitioner or an obstetrician gynecologist. They're all primary care doctors. Where do you get this? I think when people can't find a doctor or the doctors are all full up, then they begin thinking there's not enough doctors to see me. But I don't know if people are realizing that there aren't enough primary care doctors being trained. Beautifully. I'm of an age where it's time to be thinking about retirement. I've been worrying for 2 or 3 years about what happens when we close the door to Noble Clinic. But right now I'm stuck in the position of thinking that I'm important and what am I going to do and how can I really bow out. It's probably not realistic to think someone is going to take over the practice, and so it probably will eventually close its doors. We'll transfer our records to whoever our patients want to be their next doctor. I don't know who that will be though.
Present models of care are great for physicians. They just happen to be terrible for patients and the profession. The mix of providers is really governed by supply, and the supply for rural areas is extremely limited. It takes us about 10 years to recruit one physician.
Having a sufficient supply of primary care physicians is not just a problem in rural areas, but in all communities nationwide. Harvard Medical School is working to prepare students to become primary care physicians. But as Dr. Valerie Stone at Massachusetts General Hospital notes, there are a lot of challenges awaiting students interested in going into primary care.
The job opportunities are numerous. However, there's some challenges. One of the things that concerns many people is what's called the uncontrollable lifestyle in primary care, where in fact the doctor feels responsible for their patients 24/7. Basically, every day of the week and 24 hours a day, and most young people aren't looking for jobs like that anymore. The other one is the issue that most people these days want to be an expert, and it feels like the knowledge base for primary care is potentially so large that it may be too vast to be knowable for many, and that's a concern. And then finally, the compensation in primary care is lower than most other medical specialties. And when you're talking about the largest knowledge base and the most amount of time being on call, it seems like a mismatch for the compensation to be lower. So those are the challenges in filling primary care. It makes burnout common or possible, and it also are things that we think the healthcare system ought to be addressing.
The history of primary care really in the United States dates back to the history of general medicine and the personal physician, which is really rooted in American culture. You know, the typical Norman Rockwell picture of the primary care doctor as somebody who is central to a community, who is the go-to person, who's very humane but also maintains a discipline in medicine and in learning.
Over time, primary care became more organized, and there was a need to develop better training. In the 1960s, with pioneers such as Dr. John Stokel leading the way, training of family doctors or generalists changed, requiring them to have more in-depth training and scientific knowledge.
There was awareness that the training was developing a missupply of doctors. So there was a dearth of primary care doctors, if you will, to take care of the population in both rural regions and cities. Outside of medical institutions, there was a recognition publicly and politically that something needed to be done.
President and Mrs. Johnson and Vice President Humphrey arrive for ceremonies that will make the Medicare bill a part of Social Security coverage. The new bill expands the 30-year-old Social Security program to provide hospital care, nursing home care, home nursing service, and outpatient treatment for those over 65.
Along with the implementation of Medicare and Medicaid in the 1960s came other challenges for the primary care physician. With the implementation of health insurance, physicians were no longer operating as a cash business, but had to hire administrators to file paperwork for insurance reimbursements. Managing a business meant less time managing patients.
As medicine became more of a business, the way the reimbursement system was set up, and some people can say sort of by accident, but it was based on a fee-for-service. And so what happened then was that when you go to the physician now, you go to a primary care doc, and they diagnose you, and he may hear something that's a little off with their heart. So he wants to send you to a cardiologist. You go to a cardiologist runs a battery of tests. The cardiologist then gets reimbursed from insurance and such thing as the federal government, Medicare and Medicaid, for those tests, a fee for a service. Cardiologist provides a service, gets money. The more services they provide, the more money they make. And so what happened is there was a draw away to the specialty that could make a lot more money because they could offer many more services than a primary care doc could do. So the business model pushes the fee for services, the reimbursement structure, to the specialist. And so where the money goes, people go.
One doctor who suffered the effects of the reimbursement system firsthand is Dr. David Dumont, a primary care physician who had to close his practice.
Primary care physicians in general are facing more red tape, more paperwork, more insurance interference with delivery of care when they're just trying to provide the best care they can to the patient sitting in front of them, but then has to spend hours getting authorization for treatments, for medications that provides no benefit except to the insurance company. Payments are not increasing at the same rate to primary care physicians as they have been the past 20 years to specialists. I was in private practice for 18 years doing family medicine and found that there were increasing hassles in practice, and it was interfering with my ability to provide good patient care. When the hospital offered me a position that was going to be a salaried position, it made much more sense for me and my family.
There is very little uniformity in reimbursement. If I have a patient with ingrown toenail, for example, and I treat that in the office, Medicare will reimburse me for an office visit somewhere around $33. If I were a podiatrist, however, with the specialty of foot care, they would pay me 3 to 4 times that for the same procedure.
Urban communities also endure the challenges of reimbursement for care. Doctors at the MGH Chelsea Health Center, right outside the center of Boston, have seen firsthand how the demographics of the community affect payment for care.
Chelsea's unique in that it has about 35,000 residents. About 60% of our patient population is Latino, speaks Spanish, and very poor. We have about 40% of patients at or below 200% poverty level. We have some unique challenges that are unique to the health center. We have patients who have decreased access to health care based on their socioeconomic status. Patients are here working 2 or 3 jobs, single moms, patients that are unable to get to appointments, so we're trying to reduce some of those inequalities of healthcare delivery. Maybe you should be on a low dose chronically in order to prevent any more flare-ups, because you've had, what, 4 in the past 6 months? How many?
Yes, to at least try it, because this is not a quality of life for me. It's not, doctor. It's awful.
I know. No, I mean, I
know,
can,
and I know you understand.
Empathize. Yeah,
I know you.
It can be hard. You know, it's a lot of work to take care of patients. You know, the medical aspect of the patient, but then also the socioeconomic factors that weigh into their care. That can be very challenging.
In the hospital, like I have the type that comes out of the wall, the liquid.
Yep.
Medicare won't pay for the liquid, so I only get this. This is, I don't know, 21% I don't know. They told me the stats on it. I can't breathe good on this.
I know.
I really can't.
While some doctors struggle to find cost-effective ways to treat patients and keep their doors open with the current reimbursement structure, Dr. Edward Rappel, a solo practitioner in Hamden, Connecticut, has been able to use health information technology to sustain his practice.
I believe that if the providers are able to not only implement but actually to adopt health information technology and to make sure that that health information technology is going to improve the quality of care for their patients and their populations, they can build into their practice methodology a business model wherein they're able to enjoy improved reimbursements as a result of that.
Blow, hard, go, 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 keep going, go, 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 go.
Technology has helped me as a solo practitioner in a variety of ways, most of which are convergent with the needs of the patients, of the community, and the healthcare system, as well as the success of my practice at the same time.
His work with technology makes it easier for me, mostly in terms of a real convenience. It makes it easier for me to find out what's going on. He knows how to use e-files. He communicates that way. I can chart my visits. I can chart my cholesterol, my LDL, my HDL, my triglycerides, everything, just by going through the portal, which I found very, very useful.
Health information technology benefits patients by allowing them to track their own medical history. Primary care physicians are able to reduce costs by using the technology to better manage their patient population. Technology is only one way primary care is moving into the 21st century. As populations change, so do the models of treatment.
As we're trying to fit the needs of the population, what works best for the largest number of people is to look at more team-based models. And so the new move towards patient-centered medical homes is probably the most important trend in primary care innovation, in which patients will belong to what's called a patient-centered medical home, and there will be a team of providers who are responsible for each patient, and the physician will no longer be the only one who's responsible for that patient. The responsibility for the patient will be shared, and the patient will understand that they may see different providers for different visits and for different needs that might come up.
I think for medical students and residents who are coming through the training system today, they need to embrace the concept of the patient-centered medical home, as it is not something that is going to go away, and it is a model that is going to definitely improve their ability to provide for patients' care by really reinforcing the team approach as well as being patient-centered
We've come to the recognition that it's not just the doctor in the exam room with the patient any longer, that so many people contribute to the care of patients, and that the evidence is very clear that when we function well as teams, patients get better care. And that's something that we're really trying to have the students recognize from day one, that it's not just the doctor who's involved in the care of the patient. There are many, many, many people, from nurses to CNAs to occupational therapists to physical therapists to discharge planners to community members involved in the care of patients.
Historically, in health professions education, we have tended to educate in silos. And then we unleash these new graduates out into the healthcare workforce, and they enter a hospital setting, the ED, the ICU, the operating room, and we say, go be a team. The hospital is expecting them to function as a team. And we've not really done a great job of educating them, prepare them for that.
As primary care evolves, so too does the way medical schools train their students to become primary care physicians. At Quinnipiac University's Frank H. Netter, MD, School of Medicine, students are trained to work in the patient-centered medical home model.
Quinnipiac is in a very unique situation in that it has a long history of training healthcare professionals, physician assistants, nurse practitioners, physical therapists, occupational therapists. And the one component of, if you will, the healthcare team that was missing was the physician. And so it's logical that under the circumstances, given the national need for physicians, it was natural to build a medical school here at Quinnipiac. And I think we have a unique opportunity to build a medical school of the future.
Building a medical school that focuses on working in teams to provide primary care will only do so much. Providing students the opportunity to become interested in primary care during medical school and residency will help decrease the shortage of doctors.
I don't think primary care had necessarily been on my radar until I sort of on a whim decided to do this continuity clinic as part of my 4th year of medical school. I just thought, oh, that'd be a good experience with outpatient medicine. And I think it really changed my life. I mean, it changed what I wanted to do. It was the first time where I felt like patients really belonged to me and belonged to me in sort of this longitudinal way. I felt responsible for them, or responsible for my part in taking care of them and helping them be healthy. And I still think about those patients all the time.
We can recruit an entire new generation of primary care physicians if we make clear that here are the expectations. They're high, but the support is high. And I was very concerned 5 years ago that I'd be shutting off the lights of primary care when I left. I'd be the last one, in the room. What we're really finding is there's an excitement around the country among medical students for primary care. It was always there.
My name is Deep Shaw. I'm a 3rd-year medical student at Harvard.
She is a 92-year-old, and she has recently had an episode. So she's here today for follow-up of this particular problem. She may have some other issues as well. And your job today will be to sort of do an overall assessment of how she's doing.
I'm going to do a couple more tests, okay? Fine. Tell me if you can feel this vibration on your toe, okay? Okay. I think the opportunity to build a relationship with any person can be enriching, particularly when they come to you as a patient. Usually, they're going through something that's difficult, and you have an opportunity to kind of shepherd them and just walk them through that. Not necessarily as kind of it used to be a more paternalistic model, but now we really try to treat our patients like equals and think of what it would feel like to be them. And I think that's just a privileged position to be in, to help people that way.
As medical students become our next primary care physicians, the one constant that remains is the importance of the doctor-patient relationship, a vital connection valued for generations.
You start to build relationships and you build a trust between your doctor and you, and it makes it easier for patients to come to you as the PCP to ask you very personal questions. I mean, I've always said this is a privilege to be a doctor.
Good morning. Hello, Kathy. The doctor-patient relationship is one of the most important things one can have in trying to provide their patients with the best care possible. I think when a patient comes in and meets a doctor, who remember something about them that they know is not in the note. I didn't write it down. I think that really makes it different to the patient because they feel that the doctor, gee, she remembered that about me? That's amazing. How is Ron?
He's doing really well.
And Elizabeth?
She's well also. Yeah.
And how's, did you put in, were you talking about new decking or something last year?
Oh,
Did
yes,
Ron have a
Ron
project?
took care of
that
that.
He took care of it?
He did. He did the whole thing.
I think that makes a patient feel special, that of all the things you had to remember about me, you remember that little thing about me. And it makes them feel special that despite the fact you have tons of patients, that you still remember them as an individual.
Hey, me again.
Hello, nice to see you.
You've been paying a lot more attention on the diet, so you're really owning that in a way which is great. So, excellent job. The relationship is, for many doctors like myself, is the centerpiece of what makes us love the work that we do. The best stuff that happens when you shut the door and it's just the two of you sitting really is in the conversation, the communication that goes on. Sometimes the person just needs to come in and talk about what's happening in their life, and you don't necessarily even need to do something. They just may need an outlet to share their concerns and their fears, their anxieties about what might be coming, what might be happening to them.
What would happen if...
Don't even say it if he changes. The kind of person I am in my age, I don't like changes. And I keep telling the girls, he's not gonna leave, is he? He's not gonna leave, he's not gonna go anywhere, is he? I don't know. I don't know what I would do.
So what does it mean?
Dr. Sussman is very thorough. When I see him, he tells me the way it is, and sometimes I need to hear that.
You're not smoking?
I'm smoking right now about 10. I know I'm down from 40 cigarettes to 10.
What can we do to get rid of those?
Goodness gracious, cut my hands off and sew my mouth up.
I can do that. After you've taken it for twice a day for a week, you throw the cigarettes away.
Yep.
And you start the patches.
Okay.
Okay, so you don't have to use the patches in the week between if you want.
Right.
Because we want to give you a little bit of time to get this stuff on board.
Mm-hmm.
You can stare at that and hopefully fill it. Because it is...
I'm gonna fill it.
In terms of everything we're telling you to do, that's actually more important than just about anything.
Right.
The cholesterol, anything.
Yeah. No, I know.
The joy of primary care is patient relationships. Our present models are doing everything possible to devalue that relationship. Physicians are punching time clocks. Physicians are handing off multiple times the care of patients. And as a result, that relationship with the patient is being pushed to the side. We need models that promote that relationship.
Pull it apart and put it in your ears.
What about the future of primary care? Well, if everybody recognizes that this is important, I have great faith that eventually, after trying everything else, we'll come back to primary care and to rebuilding it. In fact, it's not a hope, it's actually happening.
Primary care is most likely the saving grace for the future of medicine in this country. I believe that primary care is going to be one of the cornerstones of the improvements in quality of care that our healthcare system so desperately needs.
Primary care, hopefully with good support from the government, from medical schools, from academic medical centers, we can start to cultivate, the desire for students and residents to actually go into primary care. If they see that we're happy, they hopefully will follow and consider a career in primary care as well.
I think being a primary care doctor is one of the most fulfilling things one can do. There is not a day I go home that I don't say, I think I helped somebody today. Whether I do it, consciously or unconsciously, I sleep very well at night knowing that I've impacted someone. And I'm going to see that person again to continue this relationship. I treasure the relationship with my patients more, and I think that's what's in it for doctors today. And if they can remember that, that's why they went into medicine. I think it's an easy ride home.